the first thing we would start with is, does the drug do something useful, right? So that's the same analogy of, does a car run? Now, if you were to go back and ask, today, how do we decide that? We don't. We assume that because the FDA has approved something, that it does work. But we're not asking, but what's the definition of does it work?
You're listening to Self-Funded, the podcast about making healthcare better together. Let's get to work. All right, well, I'm excited to have this conversation. We're going to talk about the inefficiencies in healthcare and specifically in the pharmaceutical drug world and the PBM world. But Pramod, why don't you introduce yourself really quickly? And if you want, in your own words, give us the high level what this episode's going to be about today.
Well, thank you very much, Spencer, for the chance to chat today about a topic that we all care about and we talk about a lot, right? Which is the inefficiency of healthcare and healthcare costs. It's a constant thing that, whether it's Washington, whether it's in the trade things that we look at every day, we talk more about the cost of healthcare than we do the quality of healthcare.
Oh, all the time.
Right? I mean, when was the last time we talked about the quality of healthcare? I mean, even if we talk about it, that's an afterthought because it just costs so much that we don't have time to even think about the quality because cost is such a problem. Well, today, I think that what we want to focus on really is that there's a thought today that, number one, with healthcare costs spiraling, which everybody would agree, almost out of control. It would be a fair way of, I think, describing it in everyone's mind about, it's out of control. But there's also a sense in which it's so complicated, it's so broken, there's really nothing that we can do about it except sort of little Band-Aids on the surface. And every day we talk about Band-Aids. And today we want to talk about the fact that actually, if you break down and look at why it's broken, it's actually, one of those things where you look at it and you say, I can understand that. That actually makes sense. And also walk away with it, I think we can fix this versus it's so complicated, we have no way of fixing it.
Well, that's one of the things that we had the discussion over coffee, and I want to really make sure that optimism continues to be conveyed throughout the show, because I myself go personally through waxing and waning of how optimistic I am about the solvability of healthcare, and it can be a very frustrating space to be in. But I don't think this show would do the service to the audience and to the industry if we didn't keep the optimism, because I do actually agree with you. Most of these things are solvable, whether it's through common sense, better decision-making, better data that people get access to. And ultimately, it comes down to awareness that these problems are solvable in the first place and how we do it. And I think you left me, with the 45 minutes we had over coffee, you gave me an interjection of optimism, and I'm really happy to hear that. What I would like to do today is get some of your backstory, right? Because you didn't get into healthcare immediately in your career. And then let's very clearly state what we think the main problems that are creating these inefficiencies are. And then let's talk about how you believe they're very simple to solve as well. And so for the first part of this, let's get your bio, if you don't mind. I think you have an interesting arc to get here in the world of healthcare. And so why don't you tell us in your own words a little bit about who you are?
Well, thank you very much again. I started out in the computer security space. So I graduated from college, and then as it turns out, I actually started out in the defense industry.
Okay.
My first job out of school was working for Lockheed Martin, working on the space-based laser program. If you remember the Reagan-era Star Wars stuff.
Yeah, I do, actually.
That's actually where I started. I was there for a year and a half, and then I decided to start a company with my roommate from college in the computer security space.
Okay.
And so that ended up getting sold, and did a couple of other ventures in the computer security space. And then I came to sort of a realization. I lived in Silicon Valley, right? Done a lot of venture funded things and like a lot of other people in Silicon Valley. And there was a sense in which we're the smartest people in the world. And my whole thing was that, and again, I'm sure that everyone outside of Silicon Valley takes that with a grain of salt, right? But there's this feeling of there's so much capital, VCs, venture funding, all these things. We're the center of the universe. My thing was that, well, if we're the center of the universe, why aren't we working on the hardest problems in the world? Because when you think about sort of our history as a country, whether you agreed with something or not, like you think about the Manhattan Project. And you look at something like that and you look at that was seen as of national interest and a problem that we needed to solve. And so we put our brightest and best on solving that problem, right? In the same way, we saw a lot of efforts putting a man on the moon or a person on the moon, right? All of these things that we did were seen as national problems in which our brightest and best worked on. Today, our brightest and best want to work on more advertising revenue and things like that, where you're like, I don't get it. right? We should be working on the large scale problems that really affect our economy. And I came, for me personally, as I looked at that, I came to the conclusion that healthcare was our sort of largest national scale problem. And a couple of the other ones I looked at were education and government. And I felt that healthcare was number one, the biggest. And healthcare was also the most solvable using market mechanisms versus education and government. Government is by its very definition not a market problem, right? Education, if you look at how education works, and because it's sort of, again, a very different problem, if you think about the education system in the US, that also is not really a free market problem in so many ways in the way that education works. But healthcare is one of those areas that you look at and you're like, wow, that is largely a market problem and one that we can use. It is an economic problem, which can be solved with economic, if you will, levers.
Well, so I mean, outside of perhaps direct interaction with people discussing healthcare, as somebody that wasn't really focused on the space before, I'm sure you hear about how much it costs, and I'm sure maybe you've had a bad experience going into the healthcare system or getting a big bill or whatever. But what made you keenly interested in this as a subject, and how'd you go about educating yourself how to solve the problem?
So, when I went into it, I had really no understanding of it, honestly. This was sort of like a lot of people, we have a big healthcare crisis. We're spending a lot of money on it. This must be something that we need more technology. And I come from the technology space, right? That's my background in computer security and other areas. And so this was this must be a tech problem. And so I ended up going to work for McKesson. And, they're one of the largest healthcare companies in the world, and they're very focused on the drug world. That's how my first introduction to the drug world was through my stint at McKesson. And it was also one of those most interesting educational experiences of my life. And I've had a lot of education, right? Because you get to see how real large-scale systems work, right? And so if you think about healthcare, it is one of the largest scale systems in the world. Right. We're like, what is it now? Number 3 in GDPs or something on how much we spend
I heard
on
if our healthcare sector was an economy, it'd be like the third largest economy in the world.
There you go. Number 3 in GDP, right? You're like, that's nuts and crazy. Right. When you think about that for a second. And so when you look at that from a system perspective, that's what I thought was, we just need more technology. Because if you think about most of our other arenas in business, what's been the thing that's transformed most business and forced competition? Data and technology, right? Changes in almost every industry. And so when I went in, I thought, this is just a tech problem. People just need more tech. And then you get into healthcare and you realize this is also one of those experiences of everything I thought about the way the healthcare system worked was wrong experience, right? When you're an insider, you suddenly realize, actually, that's not how it works. That's not how the money flows. That's not how the incentives work. And when you think about that sort of fundamental, it's not, what is it that what it's not is that we make assumptions in life about how things work. And I'd made assumptions about how the healthcare system works, but those assumptions come from everything else that we're used to in life, right? And we assume that, healthcare in a free market economy like the US must work similarly, right?
Or it must be rational.
It must be rational. It must be similar. All of these things we assume. I mean, contextually, the domain is a little bit different, but how it fundamentally works must be like everything else, right? And then you get into the system, and anybody who's part of the system is like, that's not how it works, right? That's not how insurance companies, when you think about the majority of employers in America being self-insured, I had no idea what a self-insured employer was, right? And I was like, there must be an insurance company. And then, the head of benefits at McKesson one day educates me about, we're self-insured. It's our money that's being spent. There is no insurance company, right? All of these notions that we have about how these things work. And you realize when you follow the money, then how the economic systems themselves work, how these businesses work, how they make money, you realize they don't really have anything to do with what you think.
$27,000, the price of a new sedan. And in 2026, it's also the annual price of family health insurance premiums. We often talk about rising healthcare costs. The question is, what can we do about it? It's time to move beyond the traditional approach and take control of healthcare costs by considering an alternative health plan. With over 1,000 clients nationwide, Imagine 360 is a leading alternative health plan delivering direct contracts with top health systems and providers, reference-based pricing for fair, predictable costs, concierge member support, a fully transparent PBM, and third-party administrative services. And Imagine 360 is revolutionizing what reference-based pricing means today. They offer a comprehensive, transparent, and cost-controlled health plan. Most importantly, with average savings of 15 to 30% and a 98% member satisfaction score, Imagine 360 helps organizations reinvest in their business and their people. So if you're a broker seeking a differentiated solution or an employer ready to offer richer benefits at a lower price, contact Imagine 360 today. Well, as you were going on this sort of journey, if you will, to get educated from the inside of the system and how it all worked, did you ever find yourself getting discouraged did you get too deep down the rabbit hole to go, actually, I don't even know if I want to solve this problem? I mean, did you ever go through those periods?
There are definitely those days in which you wonder, is it worth it?
Yeah.
Right. But if you were to go back and ask for me, that question, I'm an entrepreneur and the glass is always half full.
Uh-huh.
And so if the glass is half full, then there's always an opportunity for us to do something. And the hard problems are the hard problems for a reason. They're hard problems.
No, so that's what, to me, it's kind of the phrase I would use is it's a problem big enough that it's worth solving, right?
Yeah.
Because I think when we contextualize the cost, and we were talking earlier about how we might be able to liberate $2.5 trillion of inefficiency within this industry potentially, right? That's so big you can't even wrap your head around it. And so it must be worth solving if the scale of that problem is that big. And it also means, like one of the things you said earlier that I firmly agree with, you need to attract the best minds to it and treat it as a country like a problem that has to be solved. And it's one of the big reasons why we have these type of conversations on the show is to say, hey, healthcare is not as boring as you think. And it's not just a bunch of insurance, paper pushers going around. There's like incredible technology, incredible people in the space. And why not make it seem like an attractive place for a young person to decide to bet their career on? I want to go back to a second though. Your thesis that it was a technology problem. Do you still think that's the case?
No, not at all. Not only is it not a technology problem, in many ways, it's the antithesis of a technology problem.
Okay.
I mean, when you think about technology problems, you think about technology generally allows you to solve a problem better, right? Improved utility, right? From a cost curve perspective. And the second is it improves the cost of getting there, are the two things that technology generally does. So when you think about healthcare for a second, if you ask the question of, is the reason that we spend $5 trillion because technology can't help us do something better or remove the cost associated with something? Intrinsically speaking, yes, technology can help us do both of those things. So for example, if you were to ask, could technology help us deliver better care? 100%, right? Could technology help us lower the cost of these things? 100%. Mm-hmm. Is technology going to get us to better care or to lower costs? Very unlikely, because the economic incentives are built in ways that there is no driver to either improve quality or really lower the cost.
Yeah.
Right? And so if the economic drivers were there, then the technology would fill the gap automatically of being able to deliver those things. But it's got to start with the deficit of saying, we need more for less versus needing less for more.
Well, I think just about the kind of rugged individualism that undergirds the American spirit, right? Right now, one of the issues I see is the deferment or diffusion of responsibility for you and us as individuals because we're on some sort of employer-sponsored health plan, and or, oh, that's the insurance company's problem. I just pay my copay. I worry about how much comes out of my pocket, but I have insurance for that. So I'm not really worried about making a rational or the most efficient decision because I'm deferring that to some other faceless third party that's supposed to pay for my insurance. And so you can't capture the desire to solve it on an individual level if you're not shown how those bad decisions ultimately lead to more costs for your own employer's plan or more costs for the country. There's a disconnection between those 2 points, and therefore I'm not making the most rational decisions on a routine basis in healthcare, or I feel like I don't have enough data to make the most rational decision as well. It's how it is fundamentally different than us going to buy a TV or going to buy a car right now. And so I would ask you then, how do we start inserting some of that rationalism back into the equation for an individual to start making a better decision for health?
So when you think about it, there are a couple of things going on here, right? One is, hey, what's our incentive as individuals? Is this a consumer problem? And the answer to that is no, it's not.
Okay.
And if you fundamentally go back and ask, hey, if I'm sick, do I care? what something costs, or for example, let's make it even more interesting. If my child is sick,
Yep.
do I care how much something costs? It's like, I don't care. Do I just want them to be better? It's like, yeah.
Yeah.
If it costs $1 billion, do I care? It's like, no, I don't care. Spend $1 billion, right? So as an individual, our interests are not the same, because now if I had to spend my own money.
Exactly.
Okay.
Yep.
Then now if you're asking the question of if I have to spend my own money and what do I have to do and do I care? It's like, yeah, because I've got more than one kid as an example. So would I mortgage the house? And you're like, well, if my kid had cancer and there's a high probability that they'd be cured, I'd be like, yeah, I'd mortgage.
Yeah,
I wouldn't even think twice. I wouldn't even spend a microsecond thinking about it. But if somebody told me that, yeah, this drug actually, generally speaking, if you look at the trials, improved your life expectancy by 6 months, and we're going to have to mortgage the house to get there, and it's going to have severe side effects.
Yeah, it's going to be a miserable 6 months.
It's going to be a miserable 6 months. Then I'm like, I don't know. Why would I do that? I mean, number one, it's going to be miserable for my child. I'm not actually improving their quality of life or their life expectancy, really. And I'm going to have to sacrifice the future of my other 2 kids for that. Well, I'm willing to sacrifice if my kid gets cured all day long for the other 2 kids. But to sacrifice their future for something that isn't going to be meaningful or beneficial, now I've got to consider what's in their best interest because I've got more than one kid. And so the problem is very similar, right? Because when we think about sort of our healthcare system, as individuals, generally, we're like, I don't really care because it's other people's money.
Right.
And so it's not necessarily fair to say that an individual should be responsible to think other than for themselves, in some ways. But that doesn't change that from a society perspective or a plan perspective or an employer perspective. Is that the same view? And you're like, no. Their view, like if you remember, think about the J&J lawsuit.
Yes.
Right? J&J lawsuit's a great example of it. Talks about fiduciary responsibility. And remember, Ann Lewandowski, the person who's named in the lawsuit, she's a participant in the plan. She receives benefits from the plan. So she's the individual, right? But the fiduciary lawsuit isn't about the care she received. It was that the other people in the plan's money was not spent wisely, right? And so when you look at it from that perspective, all these issues are really about not just the individual as a plan or as a government or other parties or as a taxpayer. Your interests are not the same as the individual. But that's no different than if we were talking about park services or something else, right? It's like everything else, we got to be able to separate hey, what are my incentives as an individual when there's someone else is paying for care? Like, for example, if this is a $5 item and I'm paying for it or you're paying for it, do we care? Do we care about this line in the sand of whose responsibility is it? It's like, no, it's it's the cost of a latte at Starbucks. I really don't care to even have a conversation about this. I'm just going to pay $5 for this, right? Now, if it's a $5 million thing, why is the conversation different? Well, because if I'm spending $5 million, it's not my money that I'm spending.
Right.
It's your money that I'm spending, right? Whereas in the other case, it was my money. And so this issue comes up because there's also this understanding that we have, which is a misunderstanding when we look at the data, that healthcare spend is sort of like a butter knife, right?
Okay, explain.
Butter knife meaning that everybody gets benefit from it. And you're like, well, no, that's not how it works. If you look at healthcare spend, it's actually steeper than Pareto in distribution.
Yeah.
And in this case, what's happening is that with the higher prices of these things being mispriced in the market, these drugs are becoming more and more expensive because people can just charge more. Hospital systems and other services are going up. What you're finding is that more and more dollars are being concentrated in smaller and smaller numbers in the population. So the majority of people don't really get any benefit out of the dollars that they're putting in.
Yeah, what was the specific distribution you said of generics and biosimilars, the percentage of the plan that they make up in terms of actual prescription versus the cost? What was that
So,
stat?
I mean, you think about how crazy that is. Like if you take drugs as an example, if you took all generic drugs and biosimilars, right, and you put them together, as of end of last year, they account for 9 out of 10 fills in America. That's 9 out of 10 fills at every pharmacy, for example, in America. They only account for 13% of our drug spend.
Okay, so 90% of frequency, but only 13% of overall severity.
Spend. We could give away 9 out of 10 fills to every American, and it would cost us less just to give it away, right? And it's only 13 if we didn't give it away.
Yeah.
Right. So it's a rounding error when you think about even in drug spend. So what you're saying, what you really realize there is that, wow, the majority of people who pay premiums and everything else, their dollars, they're not the ones who are spending most of the dollars. It is going into smaller and smaller portions of the population who are on these extremely high priced and again, to be fair, inflated cost drugs, if you will. So that's a real reason is inflated hospital services, inflated drug costs, which is concentrating the dollars into a small number of people. And so imagine now if you were to take the viewpoint that all that matters is a small number of people. Well, that's what's happening now, saying it doesn't matter how much it costs for the small number of people. The other people sitting next to them are going to have to pay.
Yeah.
And when you think about specialty drugs, they're about 55% of spend. They're used by 2 out of 100 people.
So 2% of the population. Yeah.
55% of all dollars.
Yeah, I've heard an overall healthcare expenditure, it's 1% accounts for approximately 25% of the actual spend. One single percentage of the overall population costs a quarter of the overall spend. And so then it becomes, you start to get these questions, and I'm really curious your thoughts. Where people that have been paying for health insurance through their employer on their own for decades, and they keep themselves really healthy, they eat well, they exercise, they very rarely go to the doctor, they start to question, well, why am I paying so much when I'm doing all the things that I'm supposed to do for my own health? Whereas somebody else, whether it's maybe they contributed to their lifestyle and their condition, or maybe it is a rare disease they can't do anything for, but those people are paying a similar amount of money on an employer-sponsored plan for the same coverage, yet they're dramatically higher utilizers of the plan as well. You start to almost have this infighting or finger pointing that perhaps comes about. And I don't know how you solve for that, but how do we make it where healthy people actually do derive some benefit or relief in premium versus the quote-unquote unhealthy people in a plan that are being subsidized by the healthy people?
So, I mean, there are two. I think about this 2 different ways.
Yeah.
One is that for your quality of life, you being healthy and doing the right things is better for you, apart from the economic question.
Of course.
Right?
Yeah.
So there's a benefit in you doing those things, whether you paid more or less. It doesn't really matter because you're going to benefit from doing those things and living a better life, right? And having a better quality of life as a result of that. But now if you're asking the question of, yeah, but is that fair from a risk perspective?
Yes.
Because, hey, I'm a lower risk and I'm having to pay for people who are higher risk. And some people intrinsically have higher risk, but some people have high risk because they don't care.
Yeah.
Right?
Yep.
And at some point you're looking at it saying, hey, you've got to take some level of responsibility. You know, ultimately, that's a harder problem to solve.
I feel like that it is almost an unsolvable.
That's a very, I mean, that's a large public policy problem.
Yeah.
Right.
Yeah.
But if you're asking a slightly different question, which is, but do we need to overpay for all of those folks in that category? And we could have the spend there. Would that be good? And could all of us get on board with whether you're unhealthy or not, saying, yeah, I'd like to spend less.
Yeah.
Right? Can we at least get there? And the answer to that is, well, absolutely. Nothing's stopping us from getting there. And that again goes back to, it's not a theoretical complexity problem. It's a problem of the will.
Okay.
And do we have the will to do something about it?
Pareto Health is the largest benefits captive in the United States. With nearly 3,000 captive members, $1.3 billion of stop-loss premium in force, and almost 1 million covered lives, no other benefits captive comes close to Pareto Health's scale. But it's not just about the numbers. Pareto Health is a mission-driven organization, and that mission has 2 distinct parts. Number 1, to make self-insurance simple and more accessible for small to mid-sized employers. And number 2, to arm them with the most powerful cost management tools on the market. So if you're an employer frustrated with your healthcare outcomes, or you're a benefits consultant looking for an alternative to the status quo, it's time to consider Pareto Health. Pareto Health, where employers come to do self-insurance right, to do it easily, and to do it at scale. Well, yeah, you described it as a common sense problem. And even when you're talking about your own business, I do want to talk about Vivio specifically, but you were even describing it as like, hey, I'm not doing anything necessarily different. This is a common sense problem. And I'm just trying to focus on solving the common sense components of the problem. It's not this flashy silver bullet magic pill over here that all of a sudden I've got the thing that nobody else has. It's no, like, we're focused focused on exposing what the actual inefficiencies are and making it solvable. So let's talk about how you actually do that. And I don't think we actually got in to your actual business, though. I think we should at least state what it is before we get into it, because what I would like people to leave this conversation and go, you know what? It's actually not as hard as I thought. And you know what? I think we can do this. And here's exactly what I'm going to go do next as a result. So why don't you distill this down into the brass tacks for us?
Yeah. So our business is we're focused on drug management. And the reason we're focused on drug management is that drugs are really interesting. And they're really interesting because unlike other healthcare procedures or other healthcare services that we receive, drugs have nothing to do with our healthcare system per se.
Okay.
So for example, is that drug going to do anything differently for you depending on which pharmacy you got it from? It's like, no. Doesn't make any difference.
Yeah.
Does it matter who prescribed it? It's like, no. Does it matter which medical school your doctor went to? Right? It doesn't make any difference. Is it an academic medical center or not? Is that going to make a difference? And you're like, no. So drugs are really interesting because they're the one part of our healthcare system that are almost like technology in many ways, right? It's like packaged technology in a delivery vehicle. So we looked at that and said, wow, this is really interesting because it ultimately is a data problem when you think about a drug. And that's something we know how to solve because, I mean, an easy way to think about sort of what a drug does is really our focus and why we pay for drugs. And when we think about drugs is our goal is really getting the right drug for the right person at the right price. And if you step back for a second and ask, does that make any sense? And you're like, yeah, that's common sense. I've never had an oncologist or an Uber driver say, does a right drug for the right person at the right price make sense? And they're like, yeah, that's kind of intuitively obvious, right? So what the nice thing about that is that's something that all of us can look at and say, I get it. And so if you step back and ask, all right, we all agree it's a really simple idea, really simple goal, right? How do we get there? And if you go back and ask, well, how would we understand whether something is the right drug or not? And you're like, well, if you sat about it and thought about it for like 5 seconds, you're like, it's the drug's data that defines what it does. And you also realize that it's a data problem. It's not an opinion problem. Like, for example, can I change a drug's data with my opinion? Can you change a drug's data with your opinion? Can your doctor change a drug's data with their opinion? Can my doctor change a drug's data? And you realize, well, no, it has nothing to do with that. It's a data problem. It's not an opinion problem. It's not a contracting problem. The data behind it is what's going to define what it does.
Well, so what's been missing from the equation? If the data has been there, I would say for the most part, the data is there. What's been the problem then? Whether it's the digging into the data, having real-time access to it. If we're trying to get the right drug and the right person at the right time, and maybe the data has always been there, the supports through clinical trials or whatever, what's been missing in that chain of events to get that drug into the right person?
It's because the economic systems don't require the use of the data.
Okay.
Right? So for example, you and I go to buy a car, right? Today, what's the first thing that we will do when we go to buy the car? We will research every car in the class, all the reviews, because we want the data on it.
Yep.
We will ask I want to understand what the crash test ratings are, frontal versus side versus this versus that, right? We ask for miles per gallon. We ask for all of these things that are data. And we start with if you started a car company and you provided no data, who would buy your car?
Yeah.
Nobody would, right? Because we start with until we've analyzed the data, we're not going to have a conversation.
Yeah.
Now think about drugs for just a second. Who starts with that today?
Nobody.
Saying, I want to understand the drug trials for a drug. Not only that, he said, I always tell people to try this simple thought experiment or experiment with their friends out.
Okay.
I'm sure every one of us has got physician friends.
Yeah.
Right? And I always tell people, try this out. Go to your physician friends or your physician, ask them 2 questions. First question is, what are the top 3 drugs you prescribe? So give them a softball instead of making it a hard, obscure question. And then the next question is, when was the last time you read the clinical trial data on those drugs? And see what you get.
Yeah.
Because the assumption would be that everybody's starting with the data, right? You and I are asking data questions about, hey, what does this drug do, right? For example, right? And then there's always this assumption we make because in our system, we can't prescribe drugs to ourselves. You still have to have a physician who's licensed to prescribe. Well, then it would be a fair assumption that they understand all the data behind these drugs.
Well, I was thinking about your analogy. I really like that analogy of the car and how much research is done and you've got all this data and you're going in to that transaction armed with the information and you're ready to purchase a vehicle. But what's different about that versus the transaction with a doctor and prescribing a drug is I'm inherently skeptical of that salesperson. I know they're going to try to get the maximum dollar amount for themselves and try to overcharge me for the car or sell me as something I don't need. So I'm already skeptical. I'm ready to defend myself. If a doctor is prescribing a drug, I'm trusting them almost implicitly, if not explicitly, that they have my best interests in mind. They've done the research themselves and they're prescribing this drug to me because they know it has the highest likelihood of working. So by default, I'm giving them sort of authority or autonomy over the recommendation. I'm not ready to go defend myself and dig into the clinical trials and say, hey, doc, I reviewed these 3 drugs in this category and I've come to my own conclusion that this one is the best one for me. We're not doing that, right? Mm-hmm. So I think we're setting ourselves up in both of those situations differently to get different outcomes, unfortunately, because we're not personally armed with the information. We're deferring that responsibility over to an authoritative figure instead. Yeah. So therefore, we probably don't get the best outcomes as a result of it.
And as a result, even though the data is there, right, we're not starting with the data. So again, if you were to ask,
so you're saying even though the doctors in and of themselves aren't doing the clinical trials research, they're not digging into the data enough to even make the best recommendation in most situations.
Again, that's been our general experience as we talk to people. But again, there's a sense in which, and is it fair for us to expect that of an expert that we're hiring? Because at the end of the day, a doctor is a hired expert, right? And that's what they are. In this case, they're a hired expert. And there's an expectation that they understand all the details of those things, right? If we don't, then they're the proxy for us. So the assumption we've made is, like, going back to your example, is that, well, they're the purchaser for our car. And on our behalf, they have done all of those things that you said that we as individuals would have done, but they're our buyer,
right,
that we actually hired.
Right.
They must have done all those things on our behalf, right? And to be fair to them, I want to be fair to them, they're also flying blind in some cases, right? For example, they don't actually know how much a drug costs because that happens to be the person's plan that defines how much the drug costs. And every single person who comes in could have a different price for exactly the same drug.
Exactly.
And so they're also not in a position, while they may be in a position at least to look at the data behind a drug. So imagine you're a physician and you're like, hey, drug B is a generally lower cost drug and it would have worked for you. Well, what happens when you have a plan that says you got to send everybody to drug A because our formulary states that you must use drug A? So now you've put the doctor in a position where they can't steer towards the right thing, right? Even if they knew what the right answer was in this case, they can't. And they don't have real pricing information themselves. So you've built a system in which everybody has compartmentalized information, right? And you've intentionally compartmentalized all that information so no party actually has the information they need to be able to use your car analogy. You've compartmentalized the information so no one can get the answer to your question, right, in the car purchase. But if you were to go back and ask, is the information there and available potentially? The answer to that is yes. But it's not designed in a way that the parties have access to it, right? And the people in the middle have specifically inserted them in ways to prevent there from being dissemination of information.
Exactly. Well, yeah, and it's all the other big difference is if you go buy a used Toyota Camry, you have thousands of data points to say, roughly speaking, what does this particular trim level cost across the country, or maybe specifically my geography with these miles, with a clean Carfax. You have a pretty good sense within a range what that costs. You have absolutely no sense of what the drug is going to cost, or if we get into the world of medical interventions, the exponential variance between same service, same location, same doctor, but different health plan, what that plan's going to pay. And there is not really an equation of value for price at that point. And I think that's the biggest difference that makes healthcare completely separate from every other part of our economy, is you don't know what the price is going to be most of the time before a service is rendered. You find out afterwards, and there isn't a rationale as to why there's such a variance in that price as well. It's literally mind-numbingly frustrating.
And it's even worse because you have things like co-pays and co-insurance and other things. And so as a consumer, your view of the cost of an item is how much is your out-of-pocket is, which has zero to do with the cost of the item. So you've built a system in which you've also insulated parties from the true costs. And as a result, you're able to build a system in which nobody has visibility, nobody can make the right decisions, and nobody has the data that they need to be able to do it. But again, I want to be clear that does it need to be that way?
Right.
Or could we do something different and make the data available and use the common sense view? The answer to that is yes.
Yes.
So don't walk away with this thinking that this is an impossible
No, this is the time
task,
where we start to talk about the solution.
This is very much it doesn't need to be this way. It's just because the economics of the current system and the intermediaries is built in that way.
Well, so give me maybe a specific example. So let's insert your business model into the equation here. Give me a pretty obvious example of something that's immediately solvable today, right here in 2025. This is November 12th or whatever the date is. What can we solve today? Give me an easy example.
So I'm going to give you a couple of examples on a couple of dimensions, right? If we were to buy something today, like going back to the car example, the first thing we would start with is, does the car run?
Yes.
Right? So let me give you an example. Today, the first thing we would start with is, does the drug do something useful? Right? So that's the same analogy of does the car run? Now, if you were to go back and ask, today, how do we decide that? We don't. We assume that because the FDA has approved something, that it does work. But we're not asking, but what's the definition of does it work? So the first thing we do is we go back and ask the question of, does it do anything useful? And we understand that it could be approved by the FDA. Now, just to give you an example, right? The assumption that we make is FDA approval equals the drug works. There's a very public example, going to a public example. If you remember the Alzheimer's drug from a year and a half ago, Aduhelm.
I do not, but so
Aduhelm was a new drug. It was for Alzheimer's.
Okay.
Right? And it was a new drug that Medicare decided to cover. And as a result, we saw one of the largest increases in Medicare actual costs going up in 1 year. And the majority of that was because of this new drug and coverage for this drug. Okay. The drug failed in the trials. The drug actually killed more people than it actually helped. And it had severe side effects like brain bleeds and other things. It was so bad that the committee of external parties, a large number of them, some of them very well known in the industry, all resigned from the board saying, this drug is terrible. It doesn't work. It actually harms more people than it helps. The same drug gets approved, and we have one of the largest increases in the history of Medicare to cover a drug that was killing more people than it helped. Now, fast forward a few months later, about 6 months later, the manufacturer pulled the drug off the market because of the side effects.
Okay.
So you ask yourself, you start with even simple notions of even these things where we're not asking the question of, does this actually work? We should be. It's the common sense thing that we start with, which we always should be starting is, does it do anything useful and what is it?
Well, so if the baseline way that we would normally determine is, well, the FDA approved it, and so therefore it must work, or at least a little bit better than placebo. If that, we can't trust that as the baseline, how do we uncover, in your opinion, does a drug work or not?
So we take the common sense approach, right? Again, I'm going to go back to, you're going to hear this again about common sense and if we were buying something else, right? So if you start with the drug world and ask, how would we determine whether something's useful? Well, think about it. Number one is if you're sick, what's the first thing you're always looking for as a goal?
Get better.
I want to be cured. Well, I want to be cured, right? If you're sick, you don't start with even getting better. You start with, I want to be cured, right? So if we're thinking about if we had a choice between something being cured or not, where would we always go to?
Yeah, of course.
100% of the time, be cure. So goal number one is, does this cure something, right? So it's got to, I mean, ideally, whatever drug or intervention, it cures the problem, right? That's number one. Number two, if it doesn't cure something, would be, does it improve my life expectancy?
Okay.
Right? Because most of us are doing these things because we want to live longer, right? Not rocket science there. So that'd be goal number two. If it doesn't cure, would be, are you going to live longer? And if it doesn't do any of those things, then the third dimension would be, for example, I have a blinding headache. What do I want? I just want relief from my blinding headache right now, right? So what is that? That's quality of life, right? So that would be the goal. So the simple way to think about that would be, well, we'd ask the question of, well, does it cure something? Does it improve my life expectancy? Or does it improve my quality of life? And if so, how? So that's how we would start with evaluating a drug to understand.
And what data points would you use to do that evaluation?
So again, you would have to use metrics, right? For example, you brought up the better than placebo in a trial as an example. Well, the FDA has no definition of what it needs to do, even if it's better than placebo. I'll give you an example. Imagine you had a drug and it was an oncology drug, and I told you it has a 90% efficacy,
Okay.
right? That sounds like a big
You
number.
said, wow.
And
Yeah.
you're like, wow, right? But efficacy, people also confuse. And then there's another drug, it's got a 50% efficacy.
Okay.
Which drug do you want? The 90% or the 50%?
Well, you go 90, right? Just
You
with
go
that
90,
information.
right?
Yeah.
So it turns out that efficacy is the population response rate. It doesn't define what the drug does.
Okay.
It just defines that 9 out of 10 people, or 90% of the people, met the endpoint for the drug.
Okay.
Or the definition of what working means.
Okay.
Right? And so in one case, it was 9 out of 10. In one case, it was 5 out of 10, which is 50%. Now, what if I told you that, well, the 90% was that on that drug, they lived 6 months longer.
Okay.
So 90% of the people lived 6 months longer.
Okay.
What if I told you that the second drug, that it's a 50% efficacy, but they lived 10 years longer?
Right.
Now, which drug do you want?
Obviously, the second one, the 50%.
You see the problem
Yeah,
with how we use these numbers, and we're
Right.
not looking at when we don't understand what the numbers mean, and we throw 90 versus 50 or these numbers out, and people mix up efficacy, which is population response rate, with effectiveness, which is a question
Yeah.
of, but what does this do for me?
Mhm.
Right? And again, is there anything that we've talked about that isn't common sense so far? You're like, okay, I understand what efficacy means. I understand now what a drug endpoint means of what does it do. A lot of this stuff, which is all this very difficult clinical mumbo jumbo, is simple stuff that we could go back and ask simple things like, hey, I just want to understand what it does for a human being, right? That's what we want to understand out of this equation. And so going back to your question, when drugs trials are done, often trials are done on things that are meaningless. They will take a meaningless endpoint. So for example, like lower cholesterol.
Okay.
Why does lower cholesterol matter? It turns out we started with notions of lower cholesterol always equals better.
Yeah.
We found out in real life that's not true because lower cholesterol is a surrogate endpoint. And the endpoint that we really cared about wasn't lower cholesterol, it was heart disease.
Yeah.
Okay. And so what we really want to understand is not whether the cholesterol is lower or not. We want to understand, did taking this lower cholesterol lowering medication reduce the incidence of heart attacks, for example, right? And it's the heart attack that we want to understand, not the cholesterol in the
Well, I'm just thinking a pretty crude analogy, but somebody comes to you and says, hey, I want to lose 20 pounds. And you're like, okay, well, we'll chop off your arm. You lost 20 pounds. Well, but hold on, I lost the use of my arm as a result of that. So if we're just looking for that endpoint that doesn't necessarily translate, like you said, into the actual real world goal, which in that situation was lowering heart disease, well, then that's a useless endpoint. You can point that we arrived at the endpoint successfully, but did it actually do what you intended to do? And the answer is, in this case of statins, perhaps not necessarily.
Exactly.
Yeah.
And it's like, does it work in some cases? Like, yeah, it's just got a much more limited scope than where we thought, because we weren't really correlating it back to the actual endpoint or quality of life, all those other goals that we care about. And so we just ask again the simple question of, is there anything preventing us from using the data that we have to be able to answer those questions? And it's like, no, nothing.
Healthcare costs keep rising. Quality of care feels inconsistent. And for many employers, there's no clear picture of what's actually working or why. At Valence Health, we believe there's a better way. One that simplifies healthcare to reduce costs, improve quality, and elevate the entire care experience. Using an interconnected strategy, we unite patients, payers, providers, and plans to break down the healthcare silos of old. The result? Meaningful innovation that optimizes the cost, quality, and utilization of healthcare for all. Our fully integrated platform of solutions engages early and often to improve health literacy and data-driven decision-making across the entire healthcare journey, from member experience to payment integrity, provider quality, and plan performance. Together, let's create a smarter, better, faster approach to healthcare. Visit valencehealth.com to get started today.
Well, so let's actually talk about, if I'm an employer, or maybe I'm running an employer-sponsored health plan, or I know a lot of my audience is consultants. Okay, well, how do I take that logic and now place it inside of a health plan? Especially we're focusing specifically on the drug part component of a plan. Okay, your logic makes sense. Asking these questions makes sense, but applying that in the real world to get usefulness of either cost savings or higher quality of life for the people or both. okay, how do I go and do that? Why don't you describe the how?
So if you were to go, so if you go back and ask, are the people at the big three PBMs stupid?
No.
And it's like, they're highly bright people.
Yeah.
Do they have clinicians? Do they know everything that we just talked about?
Yes.
Yes, they do. So is the reason that their models lead to the opposite outcomes that we're trying to get to, and in some ways opposite of the common sense conversation that we just had, does that have anything to do with their lack of understanding?
No.
And it's like, no. But then you realize that this is not an information problem of, it's just that the people at the big three need to be educated. And you're like, no, that's not the problem. Is the problem that my health plan or somebody else just needs to use more data? And it's like, no, that's not the problem. The problem is that you've got an economic framework in which they make money by these conditions being true or false, right? And so if you were to go back and ask, how do you fix it? Well, you got to choose an alternative that works differently, right? And so, and I'm not saying that we're singular in this, but there are people like us who've said, we're going to fix this by offering an alternative that works differently.
Yeah.
Right. So in our world, we went and tried to solve the problem by saying, well, could we build a model that just does the common sense thing? Hey, does this work? Are there alternatives? Are we overpaying for the same thing? You know, the common sense things that we would do, like if we were buying a car. Is there something that prevents us from doing that? It's like, no. So we just built a system that said, do we need to build a PBM, for example, that's like the big three, but slightly better? We're like, no. Why? Why do we have to stop at saying we're slightly better?
Well, so is your argument perhaps that even the PBM paradigm is sort of outdated and needs to be replaced with a new, not just a new, slightly better version of a PBM, but maybe something distinctly different altogether with a different goal perhaps than a PBM traditionally has? Is that, I don't want to put words in your mouth,
Yeah,
but is that
I
safe
think
to
that
say?
not only is that the case, it's that, and what would that look like?
Yes, yeah.
Right? If you were to ask
I think the
question,
audience
right?
would definitely
Then
want to know, what does
like?
that look like? Yeah.
It would look like all the other stuff we buy in life, right? Because we've been told that it's so complicated that no one can make sense of any of this stuff. And what we want to convince everybody is that's not true. If something as complex as a drug, we can actually go back to the trial data and understand what it does, right? We have the data. We can understand it. As complex as something like, are there alternatives, which are the things that we deal with every day in our lives? We can actually look and say, hey, are there alternatives or not?
Yeah.
Right? We can compare things. Right. And for example, do we need to pay $10,000 for a $30 item? I mean, imagine that Mark Cuban Cost Plus Drug sells a drug for $30, and in the J&J lawsuit, you know, in this case, since public information, Pareto sells the same drug for $10,000. If you went to a 10-year-old in America and asked him, hey, what's the market value for that drug? How many of them are going to say $10,000?
Right.
Nobody. Everybody would say, yeah, it's $30. So does someone wanting to charge $10,000 for a $30 item make it a $10,000 item? It's like, no.
But at what point, and that's what maybe these J&J type lawsuits are contending, at what point is that actually criminal in nature? It's not just an egregious overcharge, but in that example, if it's a $10,000 charge for a $30 drug, when does that deviate into the realm of criminality? Because how would you possibly defend or justify that at some point when it's so obvious, perhaps the disparity between those two things just you can't defend it at some point, right?
Well, I mean, you and I are probably having the conversation of, we as just average human beings, average Americans, are like, I don't know how we defend that, right? It'd be a hard thing that you're at a dinner party and you're trying to explain to your friend who just paid $10,000 because you told him this was a good idea. I'm sure most of us would be like, that's the dumbest thing I've ever heard of, right?
Yeah.
But if you step back and ask, you know what happened with that J&J lawsuit? It got thrown out in the court. And largely, you know what is thrown out? One of the reasons it's thrown out is that the argument that on the other side that they're making as a rebuttal to the lawsuit is that we did everything that we could. We hired the biggest PBMs in the country.
Right.
We used the best consultants in the country. We did everything that was commercially reasonable in this case. So you can't hold us at fault.
Yeah, but the thing is, to me, J&J being a manufacturer of drugs and negotiating with PBMs directly in and of itself, that argument doesn't really hold water to me. And I'm not a lawyer, and I'm sure the reason for the suit being dropped maybe technically was correct, but arguing ignorance in that situation doesn't really pass the mustard for me personally, because they're actually in this space. That's what the business is in and of itself. So deferring and saying, well, my consultant recommended it to me, or we picked this PBM because they did this whole procurement shenanigans RFP, and we came to the conclusion it was this that. To me, being in this industry, that's just nonsensical. But okay, I mean,
but that's the difference between the law and common sense.
Yes, yeah,
right. And I think we're having the conversation about, but does that pass muster for anybody from a common sense perspective, right? And I think all of us look at that and say, that makes zero sense. That makes zero sense when a hospital down the street, in the drug world, at least we have a fake price called AWP, right?
Yeah.
And so at least that's there. So it's like an MSRP. I mean, you can't really charge above AWP, right? Above that manufacturer's suggested retail price. But in the hospital world, routinely, and some of our most well-known NCI cancer centers have some of the most egregious pricing in the country, where they will buy a drug from a manufacturer and they will mark it up by 5x, 6x, 10x. Imagine a world where somebody can buy a car that you bought. They could buy the Honda for $30,000, and now they can sell it for $300,000. And they can force you to pay $300,000 for a $30,000 Honda. Imagine that world in which, how is that possible?
Well, but it is possible. We know that. I don't have to imagine it, but I would like to imagine the world where that no longer goes on anymore, right? And so you're introducing common sense, you're introducing data, maybe perhaps pausing, right? Because I think one of the things you told me about the world of pharmacy is it's in real time, not necessarily like in arrears like medical interventions are, where we get billed and then it's revised a couple times, then there's an EOB, and 6 months later, or whatever the case, we actually get to that claim being paid. Pharmacy has an element of real time. I get prescribed something, I go to a pharmacy, it's flagged immediately, it's about to be filled. We have the ability to perhaps intervene and pause at that situation, correct?
Yeah, that's absolutely
okay.
Right.
So what would that pause look like in a model you're describing?
So in this world, right, we would look at that and say, for example, can we make sure the drug is doing something useful, right? So the pause could answer questions immediately of does this drug actually do anything or not? So imagine that pause, as you put it, allows us to be able to ask those questions for the first time of, does it do anything? And if it doesn't, why would we pay for it, right? We'd say, look, this doesn't do anything.
So then it would essentially say, we will not fill that script.
Exactly. We were able to say no, because at some point, remember, with these expensive drugs, it's not the person who's receiving the care who's paying for it. It's the other people in the plan. This whole fiduciary lawsuit is not about protecting the interests of the party who's receiving care. It is about protecting the interests of the people who are paying for the care that person is receiving. So in this case, there's an obligation not only to make sure that that person gets the care they require, there's an obligation to make sure that it's doing something useful and the car runs that we had to buy for this person. Right. And in the same way, we can also look at, are there other alternatives that do the same thing? Right. Because that's the other common question. So now that pause allows us to look and say, hey, what are all the alternatives that are on the table for this person? Right. And can we look at all of them rather than saying, a formulary tells me that I must do A? Instead, I can say, I don't have a formulary, right? I can look at all options and look at, hey, what is the best option for this person? Right? And then the pause also allows us to say, that's a $30 drug, and we're willing to pay $30. We're not willing to pay $10,000.
And does that need to go back to the doctor for approval if we were going to attempt to switch to a lower cost alternative at that point? Connecting back to the doctor to say, hey, do you agree, if you will, that this is an appropriate alternative to the drug you prescribe?
And the answer to that is it depends. So for example, if it's a different drug, right? In that case, it'll almost always have to, I mean, not almost, it has to go back to the physician if it's a different drug. If it's a generic, never, right? If it's same person is selling the same drug, someone's selling it for 10,000, someone else selling it for 30, don't need a doctor's so
does that look like redirecting them to a different pharmacy?
Different pharmacy, right? So it doesn't require any sort of intervention on the physician's part. And then the biosimilars, if they're interchangeable, as an example, even for a biosimilar, for an interchangeable biosimilar, it doesn't require physician's approval for that.
Okay. See, that type of real-time intervention is intriguing. With the goal is you're not necessarily disrupting the doctor prescribed care per se. You're just adding intelligence and a little bit of caution perhaps into just not immediately filling that prescription, having the plan pay for it and move on. And as long as, I guess, there's a voluntary component to the member has to say yes to it, I presume as well. And it's at the very least, not going to be to the detriment of that person. In all intents and purposes, it's to be the benefit of the person. If those things are true, then you start to ask the question, well, why wouldn't we do that?
And in some cases, it's not voluntary, right? Because it's voluntary when it's your money that you're spending.
Fair.
But for example, when you run into that 2% who are driving 55% of spend, remember, it's not their money that they're spending. At that point, there's also a responsibility for the 98 people who are paying for that care to make sure that their interests are preserved also, right?
Mm-hmm.
Their costs are not going up. The way to think about it is that for the majority of things, as it turns out, it doesn't make any difference. So like in our model, we looked at this and said, you know what? For about 95% of things, it doesn't really make any difference where someone gets it from, what drug they're on, whether they got 30 or 60, 90. We don't need to put in narrow networks, and we can make it convenient to say, if you want to go to an independent, go for it. If you want to go to CVS, go for it. If you want to go to Mark Cuban or Amazon, go for it, right? That's 95 out of 100 things. But for 5 out of 100 things, those things are the very expensive things. And that's sort of like that 95% is sort of like going to a grocery store and buying groceries. It's like buying lettuce. Buy lettuce from wherever it's convenient.
Right.
But when you and I buy cars, do we buy cars in the same way that we buy lettuce?
No.
It's like, no.
Yeah.
Why? Because it costs a lot.
Yeah.
And we got to pay for it for years.
That's like my wife getting everything at the grocery store that's on the list and then deciding on $100 bottle of wine instead of a $15 bottle drinking. It's like, well, why did we get this one instead? Well, that one choice was 25% of the overall grocery bill. Well, maybe we shouldn't have done the $100 bottle. And so it's those choices that have an outsized impact on the total that you're trying to intervene, those rarer circumstances, not the generic lettuces and which bread to buy and things like that.
And so in our model, we've said, look, for the common stuff, it's the opposite of everybody. Make it easy for everybody, open it up. And then for that 5% that are driving literally almost 80% of your spend, that's where we need to go in and make sure, is it the right drug for the right person at the right price? Because it's a huge cost impact. And if you're somebody who's trying to make money, imagine that, remember, we're also trying to battle the other side, which is people want to sell you things, right? That's how they make money. Where are they going to try to sell more with the higher margin? On that 80% for the 2%?
Of course.
Or on a car or on lettuce? It's the car that has the higher margin, not the lettuce, right?
Which is why, going back to the formulary conversation, it's why the formularies are often designed by these big 3 PBMs to incentivize the worst choice in terms of economic outcomes, because there's a benefit derived by that PBM in the form of a rebate. And so you create an incentive structure that makes the member, makes it easy for them to go get that drug filled. So then we extract the rebate out of the equation as a PBM. That's so irrational when you actually describe it versus, well, what are you actually doing that's any benefit to anybody but you as the PBM? And the answer is there is no additional benefit. But this middleman has inserted themselves, has suggested that their involvement and their scale and their leverage will bring down drug prices. The reality is they've set up a formulary and incentive structure to drive up their rebates and to drive people to higher cost medications instead. So one of the things that you said earlier that I like is, could we get rid of formularies altogether? Is that a possibility?
Oh, well, I mean, not only is that a theoretical possibility, when we launched our first product in the specialty space in 2017, that is exactly what we did. So we moved it from being a theoretical construct of could this be possible to saying absolutely. Yeah. And not only is it possible, it's, most of our customers have saved between 30 to 50% on what they were spending just on specialty alone in that category by taking the common sense approach. So it's not a theoretical question of, is this possible? It is 100% that we've proven with data. And so what that really means is that, again, is there any real data-driven reason behind these formularies other than it improves profitability for the pharma industry and for the PBMs? The answer to that is no.
Hey guys, I want to take a moment to tell you about Samaritan Fund Program, because what they're doing right now is incredibly important for employers and brokers. When an employee faces a serious medical event, the financial stress alone can be devastating. not just for the family, but for the company as well. Productivity drops, morale suffers, and healthcare costs can skyrocket. Samaritan Fund program steps in during those moments with direct financial support for the employee, helping cover life's real expenses when they need it most, while giving employers a powerful tool to manage large medical claims and overall benefit costs. It's more than just assistance. It's peace of mind to heal. If you're an employer or an insurance broker looking for a smarter and more compassionate way to protect your people and your bottom line, learn more at SamaritanFundProgram.com. Well, so let's talk about some other components in this chain of events. So I think of the big levers typically you can pull in order to save money on pharmaceutical drugs, right? You have components of international sourcing I'd like for you to touch on. You have PAP and MAP programs. And then you just have literally, can we procure the drug at a lower cost than what is being charged to the plan today? And then maybe last but not least, you've already talked about, but biosimilars or generic alternatives. So of those kind of 5 key categories I listed that most plans are attempting to in some form to lower spend, which ones are the most important in your model?
In our model, none of the above, other than the lowest cost. And it's really our real focus is on common sense, right? Looking at it from a common sense perspective. Let's take international sourcing for a second.
Yes. Yeah.
International sourcing, as an example, is just saying, I can acquire this drug for less.
Yeah.
Right? Because that's the whole point of it. You're not doing anything differently other than the right price question, right? In that sort of right drug, right person, right price. You're looking at the price saying, I can acquire this drug for less somewhere else, right? It still doesn't answer the question of, is it the right drug? Right. And is it going to do anything useful, right? So it helps on that front. Now, from a general perspective, if you were to ask the question, systemically, is this going to change anything in the US? The answer to that is no. And the reason why is that could you as an employer potentially save some money with international sourcing? It's like, yeah, you could. Is it going to make any difference nationally? No, it's not going to. Like Canada, our number one source of, for international, for drugs, for example, they're slightly larger than the population of California, okay? California as a state that I live in is almost the size of Canada, okay? What's going to happen if a significant percentage of drugs get diverted from Canada to the United States? All the drug manufacturers are going to put in export restrictions, saying you're not allowed to export because these are all government-regulated contracts with drug manufacturers, right? And all of them are just going to say, you can't do that. And so you're running into this issue for branded drugs where this matters the most. They could put export restrictions any day of the week. Yeah. So while it's true that as a rounding error, we could do these things, at scale, they will fail because it doesn't work. They've only got the population about California.
Understood.
Right? And so when you look at PAP programs, as you're saying, I mean, those again are all these schemes, which are really, if you look at a PAP program, it is a profit management for pharma. All of those dollars are funded by pharma companies. They're tax strategies for them to actually move dollars. And then they buy their same products at rack rate back from themselves, right? As a tax management strategy.
Yeah.
And so if you go back and look again and ask, are there some people who could benefit from those programs? It's like, yeah, you can. But at scale, number one, we've already seen in the last few years, a lot of the big ticket items are no longer real programs anymore, right? That used to be the things that drove the PAP programs. And so those have disappeared, right? And so you're finding that to be less and less, especially with rebates also. If you were to think about PAP programs, they're just another rebate strategy, right? Because you're getting a brand drug rebated, in this case, back.
Well, yeah, I think at those levers, I mean, those are, I don't want to say table stakes for, if you were looking at setting aside the big 3 PBMs, what you would want your independent PBM that is on your side of the table doing on your behalf. And you can rip the Band-Aid off on a plan and save 25 to 35% in a year just by simply doing some of those things that I just listed. But they're not getting to the fundamental question, which is what you're asking is this drug even effective or not? Or is it even the right drug in the first place? And what if the answer to that question is maybe this person doesn't even need a drug filled? Do we ever come to that conclusion well?
Yeah.
Because we're talking about unit cost, but there's also the number of units consumed. And we don't often talk about should that unit be consumed in the first place.
There are 2 dimensions on that, right?
Yeah.
One is absolutely. They may not need the drug or the drug may not work. Imagine there's only one drug in a category. That happens sometimes.
Yeah,
these are sometimes very expensive drugs.
Yeah.
Guess what? Some of those drugs have no evidence that they actually do anything useful for the person. Now, again, we make these assumptions, right?
Right.
But if you step back and you look at it and you're like, well, it doesn't do anything. And then with some of these programs, you've also got another problem, which is But what about when there's a lower cost drug for which there's the economics still have got to work out for the people in the middle?
Mm-hmm.
So when you look at a PAP program in which a vendor gets 15% to 25% of the AWP of the drug as a fee, do they get paid if a generic was dispensed instead?
Mm.
It's like, no.
Mm-hmm.
So you've got two problems there, not, of the drug not working, and now you've got incentives of a supplier who's got an economic interest still in a drug being dispensed versus a drug not being dispensed, right? And so in our model, we looked at that and said, all of these structures, the structure has got to be one that only represents the interests of the buyer.
Okay.
It cannot be somewhere in between, and it cannot be tied to the product cost itself. If you have percentage of savings and these other schemes, how do I make more money? By the percentage of savings becoming larger.
Yes.
Which means I need you on a more expensive drug. I need to save you more money. And I need to be able to show that that's how I got a percentage.
See, that's clothing shopping math, though. I need you to spend more money so you can save more money. Like,
That's
I always
right.
joke that my wife will come home and be like, well, I saved 30% on this shirt. And I'm like, well, no, you spent $40. And if you didn't buy the shirt, you would have saved 100% of the money, right? But I think the same thing you're describing is simply, oh, I've got to get you to fill or get a service or whatever so that I can save you money on the fill.
Yeah.
But, or what if we just didn't prescribe that drug at all?
But it goes back to a fundamental question of, if you were to ask, hey, why are we having this conversation at all? The business models of how all of the parties make money is in opposition to your goal as an employer. You're trying to get to right drug, right person, right price. But their models are not built around you making that being aligned with how they make money.
Yes.
So one of the key differences with what we do is that our model is aligned with the purchasers. We charge a flat PM fee. So we don't care what drug somebody's on. We own no part of the system. We take no percentage of savings or any of these crazy things. And as a result, whether somebody's on a $1 drug or $1 million drug,
well,
no
what
skin
would you
off our back.
describe this model? Have you given it a name? If it's not a PBM anymore, I've heard PBA used as a term before, but what would you describe in a perfect world, if you own this category and it became synonymous with Vivio, what would you call it?
I mean, that's a tough one, right? That's one that we struggle with. I don't know, open market drug management.
Yeah.
Or something like that, where we bring concepts like open market, because we're trying to say, this is the common sense stuff that we would all be familiar with, right? In the every other part of our lives. And so that message is like, I don't know, is it open market drug management? Is it an open market PBM? What does it look like? But it's got to have this element of, look, this is just like everything else, right? We don't need to treat them like they're special or they're different. And if we do just treat them like everything else and like a data problem and treat them like every other widget we buy, the result that we've shown over and over and over again is that everybody who does that is saving between 30 to 50% by doing the common sense stuff. And common sense and the rest of our market is something that we can scale, right? If you were to demand this of whether it was us or every one of your vendors and say no to these things that violate common sense, that will change our system.
As I think about this, the legacy way we do these things requires my brain to think, well, you need to categorize. You need to name this thing because you're replacing a thing and it has a name. It's this third party model that exists. Just like a network, an insurance network, you have to think, well, I've got to replace the network with a new thing. But the network as a business structure has been inserted into the equation, originally premised on, hey, volume equates to lower costs, but all it's really done is, again, force people through a network and driven up the cost. I think PBMs are in that same category where we don't necessarily have to name the thing that they replace. It's simply the plan needs to function the way that I want it to function. To me, as a plan sponsor's benefit as well as my members' benefits, which is lower cost and better outcomes over time. And you said 30 to 50%. That's the most commonly cited statistic in healthcare, is somewhere around 30 to 50% of healthcare is waste, fraud, abuse, however you want to describe it. It's unnecessary spend, which is where that $2.5 trillion we said at the front
that's 50% of roughly
what we're spending today.
Hey, I think that if we actually had, and this all, you remember how we started out this conversation talking about the use of technology?
Yes.
There are many ways that we could use technology in a market. If we had a real market and we had real focus on more for less, we would be able to use technology and we'd be able to do so many things that we can't do today. Can I give you one example?
Yes, please.
California Nurses Association, right?
Okay.
So in California, there are a lot of things like, for example, nurses have to do bedpans.
Okay.
And you're like, hey, do you really need a highly skilled person to change a bedpan? You're like, that makes zero sense. Now, if you go to other states, you'll find that they have like, low skilled labor folks, and low skilled also means lower paid.
Sure.
Remember, this is a cost question, right? Why would you use high paid labor to do something that they didn't need to do?
Mm-hmm.
Well, you have those, you have other positions in other states that do things like, bathing patients, changing bedpans, things like that, right? Well, imagine that you come back and you put in nurse ratios. The California Nurses Association comes back and says, well, for every X number of people, you've got to have one nurse. Well, you put a nurse ratio. And their argument is that it leads to lower quality care if you don't have, if too many patients per nurse, right? And so what ends up happening is that now a nurse becomes a fixed cost, okay, from a system design perspective.
Mm-hmm.
And you're like, well, am I going to add labor costs on top of the labor costs I already have? Because I've already got a ratio now that I can't get out of, right? I've got to have a nurse, a fixed cost. Then I'm going to make them do every single thing that is possible because they're a fixed cost that I can't optimize.
Understood.
Well, what have you just done? You built an economic system in which you've removed any ability or argument for improving the quality of what we're doing. So imagine technology there could have done things like saying, wow, we can put digital monitoring equipment on every patient, and we can actually monitor better than a human being could monitor. If I had 5 beds, we could monitor 50 patients in real time, every one of their vital signs, and understand, is there any change, right? We could understand things like, are they doing worse or are they doing better? And we could achieve better results with technology than we could achieve with people, because even if you had 5 people that a nurse was monitoring and you spent all of your time going from room to room, digital systems could still monitor every one of those people in real time and offer better outcomes.
Yeah.
Why aren't we using digital systems that cost less and could produce significantly better outcomes? And every patient wouldn't have to be woken up every 2 hours. When talk about disruption in from a patient state perspective. Why don't we want digital systems? Well, because we get rid of human labor and we have things like fixed costs for nurses and other things. And as a result, there's no economic incentive to use technology to get to a better outcome.
Yeah. Well, so then let's zoom out and end the episode. What does success look like in this disruptive sort of displacement model you have for PBMs, where we're inserting common sense and asking the right questions at point of fill? What does success look like in that space in a health plan in, let's say, the next 5 years? What do you envision happening?
The PBM industry no longer exists.
So it goes away.
It goes away.
Okay.
It's not necessary. And it gets replaced with transaction processing.
Okay.
Think Visa.
Yeah.
Think all of these other things that we do. Does your T&E platform care which Visa card or Citibank, whatever you use? It doesn't matter. It's just a method of payment. And in the same way, all this stuff gets replaced with data that drives decision making, right? Because we already talked about how this was a data problem. It's just a data and transaction processing problem. And so we don't need this PBM model and all this other stuff that is in there. We can replace all of that with software.
Yeah. Do you think they'll go away easily?
No, because they control so much of the market. And here's the thing that everyone should be like, think this is crazy. If you remember, 2 weeks ago, Cigna announced that it was doing away with rebates.
Yeah.
If you remember that, right?
Yeah.
Now imagine how crazy this is. Remember, up till the week before that, their lobbying organizations have been lobbying, telling the American people how they've saved America billions of dollars through their models and everything else, right? The same parties who've been trying to convince us how much money we've saved because of their efforts is now coming in and saying, oh yeah, that rebate thing that we were telling you about was such a great idea. Turns out you can save more just by not doing that. Well, we started doing that in 2016, telling people that you don't need to do this stuff, right? And so what they're saying is factual, right? But the problem isn't the factual nature where they are today. It's that, why do we keep listening to the industry telling us they're doing great things for us? And you're looking at that saying, I don't think so. And we keep listening to that saying, oh yeah, that's okay. And so now what's going to happen? We're going to keep playing the same game. We're going to, instead of choosing with our wallets and, in the rest of our lives, if someone took us for a ride, would you buy from them again?
No.
Imagine a world in which they're like, yeah, they took us for a ride every month, every year. It's like they took us for a ride. Oh yeah, they took us for another ride. Now we got to hire a fraud, waste, and abuse company because everyone's committing fraud. And then every year they tell us, yeah, they took us for a ride. And we keep doing the same thing over and over again, right? Does that make any sense?
No, it obviously does not.
Right.
Yeah.
And so, I mean, the real reason that we're here is that it's not a technology issue. It's not a, are there alternatives issue. It's not a, do we need to violate common sense issue. It is that we seem to have a lack of will in this country. And that's a problem that even I struggle with. I don't know how to solve the lack of will problem of because it's other people's money. I just don't care.
Well, think about inertia, right? What inertia means is you're going in one direction at a speed, and sometimes you might even be accelerating that direction. And you need an unbalancing force of some sort to change your speed or change your direction. Otherwise, you'll keep going that way. I don't know if we've gotten to the point that at scale, we've had an unbalancing force in healthcare that has caused us all to stop and change direction. I think we all know it sucks. We all know it keeps getting incrementally worse every year, but we've been able to endure and accept that over such a long period of time that we don't even know what the alternative is, or we don't have the will, like you said, to completely rip the Band-Aid off altogether and go a different direction. It feels like, but I could be wrong, it feels like we are close to whatever that watershed moment is. And hopefully it's in my lifetime, hopefully it's in my career, hopefully it's in the very near term. But there's a big reason why I like to focus on innovators like yourself and bringing you onto the show, is at least to show, hey, you can get off that train. You can leave that model. You just simply have to have the will and the awareness to do that. And so at least for us, you've presented us with the awareness piece of it. Now it's up to employers and the consultants that manage their plans to have the will to change things. So Pramod, I really appreciate you coming on, man. And thank you for making the trip down from San Francisco, California here to Frisco, Texas. It's been a pleasure. And I hopefully maybe a year or two down the road, we'll revisit this conversation and see how things are going.
Well, thank you very much, Spencer. It's been a pleasure. Thank you very much for having me.